consultant and head of department, internal medicine at Mbale Regional Referral Hospital. Today, I'm privileged to introduce you our esteemed speaker, Dr. Robert Kalyesubula, a visionary leader in nephrology, education, and global health. Dr. Kalyesubula is a senior lecturer. He's a consultant nephrologist and head of Department of Physiology at Makerere University College of Health Sciences, where he has dedicated over 12 years to advancing kidney health in resource-limited settings. His academic journey is nothing short of extraordinary, a medical degree and master's in internal medicine from Makerere University, a residence training at McMaster University, nephrology specialization at Yale University, and mentorships of highly privileged people like Professor Asad Ristaga and Mark Brezella. He has a PhD in non-communicable diseases. He has epidemiology from the London School of Hygiene and Tropical Medicine. I'm privileged to announce to you that recently Dr. Robert Kalyesubula was appointed as a fellow of the Royal College of Physicians since 2024. Dr. Kalyesubula's research has redefined kidney care in sub-Saharan Africa, and his landmark 2022 Lancet Global Health, the study that revolutionized the methods to measure of kidney function in African populations, while his pioneering based research in Uganda laid the groundwork for understanding kidney disease prevalence. His work in the BMG starkly highlighted the six-fold mortality risk for kidney patients. As a founder and emeritus president of Ugandan Kidney Foundation, he has driven transformative change that's expanding Uganda's dialysis capacity from 5 machines in 2012 to over 200 today. Spearheading the country's first kidney, he was part of the team that spearheaded the country's kidney transplant in 2023, and he has mentored a number of nephrologists to serve a nation of about 46 million. His leadership extends globally as Education Director of the African Association of Nephrology and an adjunct faculty at Yale, McMaster University of Vermont, and Charité Université Medicine, Berlin. He's a dedicated member of the International Society of Nephrology. He developed the ISN AKI toolkit, and he has been on a number of editing forums. His 135 publication editorial roles, he has about 135 publications, and he has contributed to the critical guidelines. This underscores his relentless commitment to bridging gaps in global kidney care. Please join me in welcoming a trailblazer whose work transcends borders. Dr. Kalyesubula, the floor is yours.
Thank you very much, Dr. Muyinda, for the wonderful introduction. I don't think I'm all that, but I'm very privileged to be able to present today. And I want to thank the members of the SOGA Health Forum for giving me this opportunity to be able to present. Chair, can you see my screen?
Yes, Doctor, it is visible.
Yes, I can. Yes, I can see. It is very clear and you're audible.
Thank you very much, Doctor. So I'm going to be talking about hypertension and kidney health in resource-limited settings. I have many slides. I'll slide over some of them. So I'm going to look at the global picture and then look at the epidemiology, look at what we do for hypertension, bring in the kidney disease, share a bit of the example of the work we are doing at Access, which many of us can adopt and do. And then I'm going to major on a bit of CKD integrated guidelines, which I had the pleasure of developing with Dr. Asad and other members of Uganda under the auspice of the Uganda Protestant Medical Bureau. So we know that high blood pressure is one of the leading causes of death in the world, but closely following it are common risk factors like smoking, high blood sugar, air pollution, But not very far again is the kidney disease, which comes in around ninth in the leading causes of death worldwide. What is not so good is that about 1.5 billion people are living with hypertension as per this year, and that's a very big number of our population. The African society is not spared, and sub-Saharan Africa has hypertension ranges from 20% to about 50%, depending on who is measuring the blood pressure. We did some studies in Uganda, and the presentation or prevalence of hypertension in Uganda actually varies according to the region, with the central region having up to 34.3% of adults having hypertension. Of course, for us, history, when Williams did some studies in 1941, he actually noted that hypertension was only present in about 14%. Goa noted it rising to 22.5%. And as I've shown you in this red graph, we have seen it go up to 34% in people of Kampala. But what is hypertension? So we define hypertension as a condition in which the force against the arteries is high. And usual hypertension is defined when we have a pressure of greater than 140/90, and it is all patients who are on treatment for hypertension. And it's very severe if it is above 180/120. What is worrying is that this high blood pressure usually has no symptoms, but over time, if it is not treated, it actually causes complications. This is some work we did when we are publishing work on hypertension in women, but it's very important to note that hypertension rises. It is through the spectrum of life, but rises with age. We have some unrecognized risk factors like those who are not educated, those who don't have access to treatment. People have a lot of traditional beliefs. And then we have a high prevalence of hypertension, which in some instances, or high prevalence of HIV, which in some instances increases the risk of hypertension. Then we do not have very good programming for non-communicable diseases. Up to about 8% of pregnant women also have high blood pressure. So we have about 10 to 20 million people living with hypertension in sub-Saharan Africa. The good thing about high blood pressure is that it is preventable and it's also manageable if you don't wait too long. Just before I came on air, I talked to the member from the Soga Forum, and he actually told me that we have a mixed group of individuals, and I thought I should review on how we measure blood pressure. Blood pressure varies a lot along the day, but it's important that when you are taking the blood pressure, people are seated down, they are in a seated position. They should have a seat which has back support, and the arm should be bare and supported, although there is some research that shows that if they are wearing a tight cloth, you don't need to put it off, especially for the Muslims. And I learned that when I practiced in Iran. So you use a cuff that is appropriate for the arm. These vary in sizes, and the middle of the cuff should be at the heart level. And you apply the cuff according to the instructions of the manufacturer. So you take the readings before breakfast and 2 hours after dinner. And it's important that you don't come with a full bladder. People should not have taken caffeine. That's coffee for you, no tobacco. And before taking, probably for those who are sick, your medications. And you should rest for a minimum of 5 minutes. And you should not have exercised in 30 minutes. So the devices to use vary, but now we have home blood pressure machines, and even in hospital, we are no longer using the sphygmomanometer. Many people have thought that the sphygmomanometer is actually the best, and they use it to calibrate the others. That might no longer be right if we are using well-approved automated blood pressure machines. And the sphygmomanometer actually takes a lot of time and is also user-dependent. It's important to also appreciate the different classifications of blood pressure. Using home or ambulatory blood pressure. You have, but high at this masked high blood pressure. And if you have high office blood pressure, high home blood pressure, or ambulatory blood pressure, this is sustained hypertension, almost confirmed hypertension. You might also have a case where it is normal, they take it at home, it is normal, and the ambulatory blood pressure is also normal. Then you have sustained normal blood pressure. These are the people who actually have normal blood pressure. So it should be understood that the gold standard for hypertension is actually the ambulatory blood pressure monitoring, where a blood pressure machine is put on a person and they carry it at home for 24 hours. It measures the day pressure and night pressure, and then the doctors look at that and they take the average. If someone has normal blood pressure at home and their ambulatory blood pressure is actually normal, then but when they come to you, to your office, they have a high blood pressure. That is what we actually call the white coat hypertension. But it's important to note that masked hypertension, sustained hypertension, and white coat hypertension are not innocent. They have been associated with higher risks of developing hypertension, but also sometimes with complications. We are not doing a very good job in controlling hypertension. The prevalence is about 30% as we've shared, but only about 27% of individuals are aware that they have high blood pressure. And among those who are aware, only about 18% are treated, meaning that 82% are not treated. And when it comes down to the control, which means that the control depends on the target, but generally they use a blood pressure of less than 140/90, it is actually true that up to 93% of individuals are not controlled. So I think by the end of this talk, we should be able to appreciate how to manage blood pressure and control it. I talked about this earlier on the progression of the hypertension in Uganda. The risk factors for hypertension are very common, but some are not. Some modified a study which looked at hypertension from 17 countries, published by Shakil and OG. Many of you might know OG, especially the seniors in cardiovascular. Increase the risk of hypertension. What I want to talk to you about today is the sitting, which is equivalent to new smoking. Many of you might not know this actually, but many of us sit for many hours. I use this example of where, especially you, the working doctors, or the people who sit in office, on average, they sit about 8 hours a day, and this is how they do it. They are home, where they sit on their desks. Then after that, they go for lunch, sit down for lunch, and then they sit back home in their cars going home. When they reach home, they do a bit of work, watch TV, and that gives you about 8 hours per day. Too much sitting, and that means 54 hours a week, 231 hours a month, and about 116 days per year of sitting. So I want to tell you, my friends, as you discuss with your people, that sitting too much is actually a risk factor until it causes trouble. When we are taught, we used to look at hypertension as a 4-barreled gun, one barrel pointing to your brain, one barrel to your eyes with the retinopathy, you know the different grades, and then one barrel to your kidney, one barrel to your heart, and all these mechanisms usually come through the peripheral, through the vasculature. So hypertension damages your blood vessels, and ultimately you get this complication. Now, about 10 million people live with kidney disease, and it is a common cause of death. Unfortunately, up to 90% of people don't know that they have chronic kidney disease. It is very expensive. Among those who know, also the treatment approaches are very abysmal. So it is very important that we prevent kidney disease rather than trying to treat it. Now, when you combine kidney disease and hypertension or the cardiovascular disease, then the mortality risk actually goes very high. In this slide here, it was these people, it is a New England Journal of Medicine done long ago in 2004, but it's very important. They looked at people and measured their serum creatinine of over 1 million people and followed them up for close to 3 years. The majority of these individuals were women, and then they looked at mortality as the glomerular filtration rate went down. In order for us to determine kidney disease, we need the glomerular filtration rate, and we need protein in urine, and that should have been there for the disease. But look, when they looked at the death increased as the glomerular filtration rate went down. When they looked at the cardiovascular events, they all went up, some by to below 15, and even hospitalization rates all went up. So it's bad when you have kidney disease, but it's very bad when you have kidney disease and cardiovascular. The greatest risk of kidney hospitalization increase because it is actually not the kidney disease, it is actually the cardiovascular complications. This is a paradigm, since I'm told to talk to you. Many of you know we used to define acute kidney injury as the presence of abnormalities to the kidney from 0 to 7 days. But now we have another entity called acute kidney disease, when the pathology passes beyond 7 days, but it's beyond 90 days, we call it chronic kidney disease. But the key message here is reversible. And then countries, as other causes beyond the hypertension and the pregnancy, we have genetic predispositions. So we really need to look much more than those people from developed countries. We need to look when someone gets malaria, think about the kidneys. If they present to you with the diarrhea, think about the kidneys. We've also had some studies done in Uganda. This was a study by Dr. Babua, and he followed people who had the CKD presenting to Mulago. What he noted was very important, that patients present very late. So kidney disease is staged in stage 1 if the kidney function is greater than 90, grade 2 if it is 60% kidney function, and 3, 30 to 60, grade 4 if your kidney function is 15 to 30, and stage 5, which is also now called kidney failure, when your GFR is less than 15 mils per minute per 1.7 meters. So what he noted was that over 50% of the people who come to our hospitals present with end-stage kidney disease. So they already probably need dialysis, and they found that they actually present with the LVH, left ventricular hypertrophy. We did a study that looked at about 50,000 individuals who were admitted in Mulago, and what we found was very interesting. We noted these graphs are a bit complex, but you are doctors and a few other individuals, so you understand. So you can see that infectious diseases were quite high as leading causes of death. And these actually varied when over the years, but they were coming down over the years of study. But look at the non-communicable diseases in the second on your right. I don't know whether you can see my cursor. But they increase. Non-communicable diseases were increasing over the years. And these increased irrespective of age. On your extreme right, that screen is showing you that independent of age, non-communicable diseases were increasing across all age groups. And what was also interesting is that kidney disease and hypertension were actually the leading causes of death in non-communicable diseases. So I've talked a lot about hypertension, how we treat it, with basically based on diet, exercise, and lifestyle changes, and then use of hypertensive drugs. I thought I should include a health plate here, which is familiar to you. I got this from a nutritionist, but you see you need a glass of water. You should have your plate with a coat of starch, a coat of protein, and then the rest of your plate should ideally have vegetables and fruits. So this is very important, and this is typical of what we have here. Now, you can see this man is quite stuck. He has to select from central-acting drugs, diuretics, beta blockers, calcium channel blockers, angiotensin receptor blockers, ACE inhibitors, and then all these drugs are available. So how do you decide which drug to take is a very big issue. There's a study which was done by OG in 3 African countries, and he actually showed that calcium channel blockers and then either thiazide or ARB are the best choices among Africans. And these people have developed a protocol. The Ministry of Health has developed a protocol. This was developed by MJAP. And if a person has a BP greater than 140, you can start them on amlodipine. And if the blood pressure is not controlled after 1 month, you add to amlodipine an ACE inhibitor. In this case, they used valsartan. And if the BP is uncontrolled, you increase the drugs. And then if again the BP is not controlled, you continue to pressure is persistently greater than 160/100, you consider referring these patients to a specialist. So all behind this, you have to stop tobacco, you reduce salt intake, increase physical activity, and also if people are obese, you reduce their weight and you maintain a healthy diet. Now, I'm also going to talk, of course, as the Dr. Muyinda told you, Dr. Asad told you, I am a kidney specialist, so I'm going to now delve into the kidney. So when you are treating the kidney, we use the same principles. We look at lifestyle modification, you stop smoking. We really like the renin-angiotensin inhibition. Those are ACE inhibitors or ARBs if they are available to you. I appreciate they might not be. I know you have captopril available at most of your centers, but longer acting drugs are better because we know that the fewer the number of drugs people take, the more they adhere and the more they are likely to get better outcomes. It's always important to optimize the blood pressure control. It's important to use the statins, and you can use these across the glomerular filtration rate. We have some new drugs. Today is not the day of talking about them, but we have SGLT2 inhibitors like dapagliflozin. This should be given to all patients who have kidney disease less than 60, but greater than 20 mL per minute, unless they have a contraindication to it. I'm not going to talk about GLP-1 receptor agonists, but they are coming in very strong, many used for weight reduction. You have to treat the underlying cause and many other problems as well. So now they told me to talk about what we can do at the different health facilities. So if you have a low-risk patient who has a glomerular filtration rate of greater than 60 mL per minute with a normal or a protein of trace, this person can be managed at Health Center 3 or above. And the aims of management really is to educate them to reduce the cardiovascular risk. You promote a healthy lifestyle. They should have activities, stop smoking, reduce alcohol. And then you screen for the key risk factors like diabetes, hypertension, sickle cell, and infections. Then you restrict the use of NSAIDs, and you review the creatinine and albumin after 12 months to determine whether they have CKD. If patients have moderate risk, those are the ones who have a glomerular filtration rate of 45 to 59, and they have albuminuria of less than 30, or they have a GFR greater than 60, but an albuminuria of about a 2+. Then you investigate these patients. You do whatever you did above, but you have to investigate these patients for an underlying cause. And then you try to reduce progression of kidney disease by managing albuminuria, usually with an AC inhibitor if it is not restricted. And then you also use an SGL2 inhibitor like dapagliflozin, and then you educate and health promote in these people. You screen and manage risk factors like diabetes, hypertension, and infections. If they need immunization, you give them to them. You screen and treat complications, particularly anemia at this case, because anemia increases mortality. And then you review the creatinine and albumin 6 to 12 months later. If they have higher risk, like if they have a GFR of 30 to 44 or 45 to 50 with albuminuria, then you have to manage these people at the general hospital and above. And then you review their medication, you renal dose their medications according to the GFR, you educate them, you screen and manage these factors which we have talked about. You screen and treat disease and anemia using iron, erythropoietin, and also sometimes examining to make sure that they are eating well. Then you restrict use of nephrotoxic drugs, and you refer to a nephrologist as indicated, or a physician for that matter. You check these individuals 1 to 3 months later for creatinine and albuminuria. Now, if they are very high risk, if their glomerular filtration rate is less than 30%. These are actually guidelines we have developed with the Dr. Muyinda and team. They are going to be available, I'm actually going to be presenting them next week to a big board in the ministry for the final approval. So if the GFR is less than 30, or a GFR is 30 to 45, or they have massive proteinuria, then you have to manage them at a regional referral hospital and above. And the goals of care here are you review the medication, renal dose according to GFR. These days, we all have smartphones. You just ask, what is the renal dose for this drug? And it tells you. You have to educate the individuals. You promote health lifestyle. You now begin to prepare this patient for kidney replacement therapy, which is either dialysis or a kidney transplant. And this should be done at the regional hospital or the equivalent if it is a private practice. You refer the patients, if you have controlled them, back to the lower levels, but you should also prepare them for renal replacement therapy. Of course, we also have to prepare all the patients at this time. Now, I'm going to focus a little on kidney disease. And so it's important to appreciate that chronic kidney disease is usually progressive. And however, all steps have to be taken to slow the progression of kidney disease. The slowing of progression would, of course, prolong life and will prevent complications and need for kidney replacement. I didn't include a slide here, but many of you know that dialysis ranges between 80,000 Ugandan shillings to 500,000 Ugandan shillings per session. and you need 3 sessions every week. That's about 1.5 million per week and 6 million per week. I'm sure we are all doctors. I myself, I think I don't take home more than 6.5 million. So perhaps I would not be able to afford dialysis on my own because you also have to buy other drugs. So really, it's very important that we slow the progression of kidney disease. As a healthcare worker, you should always actively identify and manage the causes and risk factors for chronic kidney disease. Okay? So now I'm going to focus a little bit on hypertension and kidney disease because that's what they wanted me to talk about. Hypertension is both a cause and a complication, and hypertension is associated with increased risk of stroke and myocardial infarction or heart attack, which are the main complications of CKD. And hypertension accelerates the progression of CKD, and it should be managed at cost to prevent cardiovascular. You have hypertension or cardiovascular disease and kidney disease, and the GFR is less than 15. Please note that the target blood pressure almost for everyone who undergoes treatment is now 130/80. According to the new guidelines of America, the guidelines of Europe, and the European Society of Hypertension. So the target is not really 140/90, but the target is actually 130/80. Unless people are older, maybe greater than 65 years, you might relax a bit of these targets. But if they have comorbidities, then their targets are also going to be needed to be lower. Lifestyle changes is important. Please note that once someone has confirmed hypertension, most of these people need more than one drug. So it's better to use multiple medications, 2 or more drugs to control this blood pressure if you are not controlling it in the first place. If you treat a person for 1 to 3 months and they are not adequately reaching their targets, you should increase the drugs, the types of drugs. Don't increase one drug. You use nifedipine is what is available to you. You go to 10 milligrams BD, 20 milligrams BD, 20 milligrams TDS. You are going to cause more side effects. Rather than increasing the dose of the drug, use more drugs with multiple sites of activity. And all groups of drugs can be considered to reduce blood pressure to below target. Once you are not hitting the targets of blood pressure, it doesn't matter so much which drugs you use as much as reaching the target itself. Of course, there are particular cases, like I've told you, if people have proteinuria, the use of ACE inhibitors would be important. So the ACE inhibitors and ARBs are first lines for lowering hypertension with people who have protein in urine, because there has been many studies that have shown if someone has proteinuria, you need to manage the proteinuria with ACE or ARBs, and you reduce the mortality by using those. Additional antihypertensives can be chosen based on the cardiovascular risk. If someone has had a myocardial ischemia or if someone has heart failure, then you have to use the 4 pillars. Using sacubitril valsartan is going to be important to you. The use of dapagliflozin, SGLT inhibitors, they also lower the pressure a bit, but they should be part of your treatment. Of course, these people would actually also be on beta blockers, which have been shown to reduce heart failure, and they should be on spironolactone. You guys have spironolactone more, but eplerenone might be better. Or if they have diabetes, then you use finerenone for the specialists. Again, blood pressure monitoring is very important. People who have CKD and hypertension should acquire home blood pressure, because we want to use home blood pressure monitoring because people are at home most of the time. So when they have to go hospital, usually you don't have enough time, you have many people in line, you can't wait those 5 minutes. So normally their blood pressures at the hospital are higher. It's better you help them to acquire blood pressure machines, automated, which they can monitor their blood pressure at home, and they come to you with the measurements. Those are more likely to predict the mortality. We know that they actually do a better job than the ones you measure at the hospital. I'm going to take some time looking at this slide, I know my time is running out. I think I'm remaining with about 20 minutes and I have a lot to share. But let's just look at this algorithm, which we have developed together with Dr. Muyinda and the group, the Dr. Chigundus, Bagashas, with the... Have we been hacked? I see someone writing in our work. Okay. So if someone has hypertension and CKD, they all need the non-pharmacological interventions. I'm not going to go over those. I hope everyone knows. We talked about them. You can include sitting there. Now, if you ask yourself, do they have proteinuria in urine? If they have proteinuria, either 2+ or more, of course, here for us, we use microalbuminuria, but for you, you use proteinuria. If they have proteinuria and they don't have any contraindication, you start an SC inhibitor or an ARB, plus minus a calcium channel blocker. If they have no proteinuria, you have to start either SCE or a thiazide diuretic. But of course, in Uganda, we mainly begin with a calcium channel blocker. And that was shown by the studies by Dyke. Calcium channel blocker like amlodipine, nifedipine, you begin with that. If they are not controlled, okay, and depending on age, comorbidities, co-prescriptions, and the stage of CKD, you can now add on a calcium channel blocker if they add proteinuria, if they are already not on it, and if that fails, you go to a thiazide diuretic, and if that fails, you go to a mineralocorticoid receptor blockade. That's spironolactone. You can use spironolactone or eplerenone, and if their blood pressure is then not controlled, you add an alpha blocker. That's like doxazosin. But many of us actually use hydralazine in this case, which is a vasodilator. You can also use hydralazine and isosorbide dinitrate. Those can work as S inhibitors. They do a good job in blacks. And then if the patient is really not controlling, you go to central blockade by using drugs like methyl dopa. And the drug that actually resolves problems is actually the minoxidil, which I found very useful. But now, if someone is not proteinuric, then you can select any of these and you keep going down that path. So this is a very important slide, and I'm not going to re-emphasize it again. So for everyone, this is how we treat hypertension in kidney disease. The question is, does the patient have protein in urine? And then that gives you the direction to go. So you should be able to do a dipstick in these individuals. I would now like to share in the next 10 or so minutes the projects we've done so that you know that these things are possible. We have a community-based organization in Nakaseke, and we set out to integrate scaling up non-communicable diseases in the district. Of course, we do a lot of things. We do education, healthcare, economic empowerment, and improving livelihoods. But because today is hypertension, I'm going to focus on the non-communicable disease program. Here, we have trained community health workers to be able to screen. This is the Nakaseke, and we are based in 3 sub-counties. That's Kasangombe, Nakaseke Town Council and Sub-County. And then we use community health workers. We engage the communities and we talk to them about hypertension and everything else. We did a census in 2016 to 2029, and we implemented another program in 2020 to 2023. And the project was really to improve non-communicable disease care. So with this, we are able to set up 3 non-communicable disease clinics, one in Nakaseke Hospital, one in Central Health Center 4, and the other one at our premises at the African Community Center, Nakaseke Life Care Center. We screened 16,000 individuals for hypertension, diabetes, chronic lung disease, and CKD, and we developed pocket doctors. This pocket doctor, you can see this is an attempt of seeing me. They have messages on one side. This is in Luganda. This is a picture of me, actually, as you can see. And we demonstrate them with a lot of pictures. And even the old people are able to at least see the pictures or even read. We have forwarded this to the Ministry of Health. We work with Nakaseke Hospital, which is a big government hospital and has a Pen Plus clinic and admits intern doctors now, and is actually looks after about 1.5 to 2 million people. So we trained the health workers, trained community health workers, got partnerships with some people from Yale and the EKFS, which sponsored this work. And we, the community health workers, now go and train others. So with the trained community health workers, we have been able to screen for risk factors using the WHO Open Guide. We measure pressure, take weight and height, measure blood sugar using a glucometer, and measure protein in urine using a dipstick. And these people have smartphones that are smart tablets that transmit that data. You can see this is a community health worker screening for CKD using a dipstick. And what did we find in our screening of 3,000 individuals? We actually noted that kidney disease was present in about 5.5%. Diabetes was present in about 1.4%, not so different from the national levels. But look at the hypertension, up to 30% in men and up to 26%, 30% in women, 26% in females. And then many people had comorbidities. That's what that is showing. We have not published this work, but we know that community health workers can actually screen. Moving forward, we've also developed the integrated kidney guidelines, as I shared with you earlier. And this has been an effort of the Uganda Kidney Foundation, Health Heart Africa, the Uganda Protestant Medical Bureau, AstraZeneca. We've consulted many of you, like Dr. Asad was very instrumental in representing the cardiology and also the regional referral hospitals in this development. This is the part of the work I shared with you has come from here, so you'll probably have access to it later. And we have also, in case people are not able to be managed or they can't afford dialysis, we have also included the comprehensive conservative kidney care model, where we treat symptoms. You look at the physical, psychological, and spiritual. You have to communicate well, involve the patients in decision-making. You have to develop a multidisciplinary team. You can replace the nephrologist with the highest level, maybe a medical officer. If you have palliative care specialists, they'll be very helpful there. Then you have a nurse, a dietitian, a social worker. All of those would be able to help you. And then you have to include end-of-life care so that you have optimal use of hospice. You look at dignity of the people, manage bereavement, and then you make sure that people take the comprehensive conservative care. And if you are able to get dialysis, yes, but you can give all this care without the inclusion of dialysis if they are not able to afford it. In our guidelines, we've also included management of CKD in women and children, so you should be looking out for these guidelines. I'm sure we'll be invited by the Busoga Forum to probably share and disseminate them at a later date. So in summary, I've told you that hypertension and kidney disease are very common and they're on the rise. Hypertension and chronic kidney disease are associated with very high mortality. And this mortality increases as your kidney function decreases. Fortunately, these diseases share risk factors and they can be prevented. According to what I've shared with you, it's very difficult and expensive to treat kidney disease. So we can prevent kidney disease and hypertension based on the prevention of risk factors. It's very important to appreciate that integrated management is the best way to go. And I've shared with you the local experience of using community health workers to screen non-communicable diseases and actually refer patients to facilities. I've also told you that we are developing local guidelines which put into context the healthcare level from healthcare level 2 to actually the highest level of care. And we are actually told to include the VHTs, which we have revised to include. And I want to thank the organizers, the Busoga Health Forum, for giving me this opportunity to be able to share with you this information. Thank you very much. Over to you, Dr. Muyinda, for the moderation.
Well, thanks a lot, Prof. That was a powerful presentation. It was full of pragmatic approaches and practical scenarios. We are really very grateful. Going by the messages and the questions in the forum, it's a sign that people have been listening and have picked up quite a number of things. And this has triggered them to produce some questions to you. Maybe if I'm to start with one, in the management, this was Dennis, in the management of hypertension, why add another class of antihypertensive on the top of the lowest dose of the initial class? Why not escalate? I think you did hint on that, but maybe you would wish to extrapolate on it more. Prof, do you prefer that I scan through all the questions, or you prefer to take one at a time?
I think I'll take one at a time.
Please, yeah.
I unfortunately can't see the questions unless
I can read them for you.
Wonderful. Wonderful.
Yeah,
so you keep reading one. I'm going to keep munching away at each. So the first one is very important. Thank you, Dennis. So for the first one, we talked about it. So these drugs, unfortunately, I didn't go into the detail of the mechanisms of action, but we usually use the ABCD. We use SCE or ARB, a beta blocker, a calcium channel blocker, and then a diuretic. Those are all first-line therapies for treatment. But these drugs have different mechanisms of action. So if you get one drug and it's not working well, when you increase the dose, it's unlikely to help you very much. But if you add a drug from another class, they have a synergistic activity and they have less side effects. Unfortunately for us now, we have drug combinations. So it doesn't mean that the pill burden is going to increase. You can combine a calcium channel blocker and an AC inhibitor. You know, amyloza H, or Synergy Plus, all those drugs. So they can be combined instead of increasing the drug. Like if you increase nifedipine, it will cause headache, it will cause edema, whereas if you are using it at a lower dose, those side effects are less likely to occur. So we prefer to use lower drugs of combinations rather than running a drug to very high levels. Another question, Doc?
Yes, thank you, Prof. And then would you prefer one ARB over the other, or would you prefer one a certain SCE over other SCE inhibitors, or it's a class effect? I think this was related to what Gonza's question.
Okay, thank you very much. So really, there are differences in classes. Valsartan is much better than losartan, but by and large, if you have made a good selection, I don't think you should worry so much about the choices. Of course, there are newer generations, like if you are talking about the calcium channel blockers, the clinidipine might do a bit better than amlodipine, but as you go higher in these classes, of course, the cost also comes a bit higher unless you are using drug combinations. There are subtle differences in the drugs, but maybe the key that I didn't talk about, you should never combine an SCE and an ARB. That's number one. Never combine them. In the accomplished trial, we showed that the mortality was increased because of hyperkalemia, so you have to always select one. Now, the selection between an ARB and an SCEI is very important. Usually, ARB is preferred because they cause less side effect of the allergy, which causes a cough and can actually also cause hypersensitivity. So if you are going to use a drug, it is better to use an SCERB, maybe perhaps better than an SCEI, but SCEIs also have their place, but they usually don't even have drug combinations. So an ARB therefore usually takes precedence over an SCEI.
Thank you, Prof. And then here I'm rephrasing Aisha Ahmed's question. Under what scenarios would you go for a drug holiday in hypertension management?
Oh, thank you very much. Drug holidays have not been shown to have benefits. The concept of drug holidays came way back actually like in we did them in HIV, now we have them in hypertension. So you could consider not actually, you could consider drug holiday if someone did not have any target organ damage. You remember the 4-barreled gun, now 5 with the peripheral artery disease. Someone should have no end organ damage, and their blood pressure should consistently be below 130/80, and they are probably using the lowest level of the drug and one drug not in combination. For those individuals who have responded very well, you could actually consider a drug holiday. The moment any person has a TOD, then they are likely to need these drugs for life, unless they were obese and you remove the obesity, unless they had obstructive sleep apnea and you treated the obstructive sleep apnea, or if they had a secondary cause which you removed. So those individuals might actually go on that drug holiday for you trying to take the drug.
Thank you. And Kalyesa is asking, when do you stop the use of SE inhibitors in patients with CKD? Assuming the patient has been on SE inhibitors, when would you decide to stop them?
Thank you very much. Very important questions. So we traditionally stop SE inhibitors when the GFR falls below 15, when we reach end-stage kidney disease, because those individuals are likely to develop more hyperkalemia. But this should be individualized to a patient and depends on the level of care you are at. So what you fear about SE and ARBs is actually hyperkalemia. But if your patient is with you and they have congestive heart failure, they have had a stroke, they have a myocardial ischemia, the risk of dying, okay, from hyperkalemia is much less than dying from the cardiovascular risk. So sometimes in those individuals, we treat the hyperkalemia by watching the diet we give them. We take away FNA, bananas, guavas, those things that contain high potassium. We even go to the extent of binding the potassium with drugs like Kalyesubula, which we have, and other potassium binders, so that we maintain the SE inhibitors. There have been several trials that have looked at what happens with people who have a GFR less than 15 and the continuation of SEARBs, and the research has been equivocal, but most people look at the cardiovascular risk the patient might have. I submit.
Yeah. Thank you. I really agree to that, especially when patients are having heart failure. And you're thinking of stopping your SE inhibitor or ARB because of hyperkalemia. There's emerging evidence that actually the mortality of cardiovascular-related mortality was high when the drugs were stopped, but when they added on potassium binders and continued the different molecules, there was a very big difference. Now, comment about diastolic hypertension. This is Charity. Isolated diastolic hypertension. Would you manage it differently?
Thank you very much. That's a very important question. So it's very important. Of course, we don't have enough time. Maybe again, my bosses might call me again if they think we are doing a good. So the understanding of the pathophysiology of hypertension is very important. So the systolic blood pressure is usually in the periphery. That is it depends on the blood vessels, and then the diastolic pressure is actually when the heart is relaxing. So the diastolic pressure is largely in the heart. So beta blockers, if you have diastolic hypertension, and perhaps the newer generation calcium channel blockers, the non-dihydropyridines, are going to work very well for you for diastolic blood pressure. But as people with blood pressures, and the trials that were done, the SHAPE trial, systolic hypertension in the elderly, showed that thiazides and calcium channel blockers help isolated blood pressures better. Of course, you have to manage the cardiovascular risk as well, but I totally agree with you. You probably need to use the non-dihydropyridines or beta blockers when you are managing the diastolic blood pressure. But of course, Dr. Muyinda, you are better than
Not really. The nephrologists are the best in managing hypertension. As members keep on registering, yes, there is emerging evidence. With the data that you've presented, most of the patients are not controlled on one or antihypertensive. The question that comes in, why not start with low doses, but in dual combination, even when it is stage 1 hypertension?
Very wonderful question. Actually, most of the new recommendations, once you find a target organ damage, or once the blood pressure is persistently above 140 over 90 after if you find someone with a TOD or a blood pressure of 160 over 90, those people should actually be started on drug combinations. Of course, when we are developing these guidelines, we develop them not for the experts, we develop them for the health center one. So many people start like that, but it's exactly right. People are starting with drug combination, usually of an ACE and a ARB and probably a calcium channel blocker. And when those ones don't work, they had a thiazide. Of course, with all these problems, I probably didn't go into the side effects of the drugs, but maybe with the questions we'll get back to them. Thank you.
Oh,
So that's a very important.
Thank you. As we wind, there were a few diagnostic questions, much as I started with treatment questions. So a few members were asking, why must the bladder be empty when measuring the BP? I think this was Jennifer. And yeah, I think that was the key diagnostic question.
So the bladder should be empty because the bladder, when it stretches, it increases your sympathetic drive, and your sympathetic drive drives up adrenaline. And when adrenaline and catecholamines go up, your blood pressure would go up, and so you get wrong measurements. Same with smoking, it will increase the vascular tone. Okay, if you are not seated properly, then the position, the pooling of blood, and all those things will actually affect the blood pressure. So it's around those sympathetic drives.
A wonderful presentation, Prof. Time is not on our side. I know there is a lot to discuss, and I encourage the CEO of SOGA Forum to invite Prof again on probably related topic or another topic. We really need to learn a lot. He has a lot to share with us. He's very practical. Members, the slides will be available. Don't forget to register with the link. A big round of applause to Professor Kalyesubula. Thanks a lot. That was wonderful. Much appreciated.
Thank you very much, Dr. Muyinda, for your kind introduction and moderation. And I want to thank the SOGA Health Forum for inviting me and giving me this opportunity to talk about hypertension and kidney disease.
Perfect. Thank you so much, Dr. Asad. Thank you so much, Dr. Kalyesubula, for this wonderful presentation. And I know people have learned from you, and I will not use very many words. I want to invite the board chair of SOGA Health Forum, Professor Peter Woiswa, to give closing remarks to this session. Over to you, Professor Peter. Members, Dr. Robert has put on his video. You can watch him. I want to pin it to everyone to see him very well.
Hello, Dr. Kalyesubula, my friend. I've only been seeing all the good things which come up on social media, and everything good that you do. Especially, I enjoyed reading your story, how you became to be from all the way down there in Nakaseke. And the work that you do, but most important, of course, also, I think for me and you, we are on the same page on many things for society. Thank you for coming to SOGA Health Forum. As you know, although you are in SOGA Health Forum, actually you are talking to the world, because all these, I don't know how many people, I saw around 350, but Benjamin always also posts on YouTube. So tomorrow you might find that you have overflown to over 500 that have attended today. Thank you for coming and for educating us. Hypertension is a big deal. And for me, I want to challenge you to start a preventive program for adolescents and teenagers. We call that the preventable fraction. If you don't get the risk factors, then you reduce this. Because that, Ugandans are quite mistaken that until you become less old is when you get at risk of these diseases. Yet the risk builds right from a younger age. I mean, we are susceptible as Black people, and you have to understand. So there's a lot of education. I'm sure a lot of people have attended, apart from doctors, but also general people. There is an uncle of mine based in Boston. So he was telling me, Peter, why don't you send this program even to people in the village? Everybody must attend. He was advertising it all over. So, it is on demand. And therefore, I hope you come back to Soget's Forum and continue educating, because this forum, just despite being called Soget's Forum, is actually to serve people in general. So I would like to give you a certificate of appreciation. Benjamin, I can't see it. I'm seeing other names.
I request for a few minutes, just I break this.
I'd like to a certificate of appreciation that you'll be receiving, and also to thank Dr. Asad Muyinda, who is a fellow physician. You guys, you're the same tribe in a specialty. Somebody said, one physician from Sweden said, you are all going to be my customers when you grow old. So, yeah, that is what he was using the talk. He said, oh, you're laughing, you think you are 30 years, but add 20 or 30. And the most important person is, she said, is the physician, because everybody is going to become a customer, which was like a joke. But she said one thing, which I think for me is the most important statement. She said, you Ugandans, you have 30 years, 20, 30 years to prepare for the burden that is coming. You have time, but what are you doing? For me, Dr. Kalyesubula, that is the challenge, because we have 30 years to get all these people who are 30 years to become 60. So how can we use this time? For us in public case, we would be happy to join you in preparing for this. How do we use this opportunity? I think we need a big campaign, even a policy engagement. So to integrate public health in clinical care, sometimes clinicians think that we don't have a role, but public health has an important role. So receive this from Soget's Forum, and Benjamin will be sending it to you tomorrow. Thank you so much, Dr. Kalyesubula. Very proud of you. And Dr. Asad, you left Ginger, but I looked for Dr. Asad this evening. He was actually going to a funeral. I said, I don't want a physician to be chaired by another physician. So, Dr. Asad, thank you for being there. Because you people speak the same language as physicians, it is only good that a fellow physician chairs. And of course, Benjamin and the Soget from CPD team, thank you so much for also always organizing this. It is a late evening, so I will not give any more talk. Dr. Kalyesubula, you can say bye to the people.
So thank you very much, Professor. I'm very grateful for this initiative, and I've taken your words to heart. We are actually trying to start an initiative. We hadn't focused on the adolescents and the youth, but that's very good feedback. We'll probably prepare for the next 20 to 30 years. And I want to thank the Busoga Health Forum for giving me this opportunity. Fortunately, my wife is a Musoga, so I think
that is another news. So tonight you are going to join the forum. So
yes, thank you very much.
How can you have the person who determines your life and you are not one of them? So please, thank you. Over to you, Dr. Muyinda, to close off everything. Thank you so much. And see you next week on Friday. Asad, please.
Thank you, Prof, for the well organized forum. There was quite a lot of learning. We need to do more and more of this. This is an ingenious platform for all of us to learn. People like Professor Kalyesubula has quite a wide range of experience, really have a lot to share, both practical and in terms of research. We really need to get more of the Kalyesubulas on the platform. I don't have a lot to say, Prof, but just to thank you for making this happen.
Well,
I'm still in the clinic. I'm yet to go back home. Yes.
Please have a safe trip. Members, enjoy your good evening. Thank you and bye-bye.
Thank you and
Thank you.
bye.
Thank
Bye bye.